Good afternoon, everyone. My name is Richard Fedorik from the University of Alberta, and we're here today with IBD TV to talk to you about the fourth in our series of IBD information sessions. Today's session is going to be really exciting. We've got a guest for you, and we're going to be talking about the surgical perspectives around Crohn's disease and ulcerative colitis. We're here at Teachers Media TV, and this program is supported in part by an educational grant from AbbVie Canada. So I wanted to introduce our guest today. We have Dr. Rachel Catteroo, who's a general surgeon and intensivist from the University of Alberta Hospital, and Rachel's going to be talking to us about the types of surgeries and some of the consequences. And of course, you know Dr. Leo Dillman, gastroenterologist from the University of Alberta, and Dr. Karen Croker, also a gastroenterologist from the University of Alberta. So let's move forward. You know the format. You've been here before. The first half hour, we will discuss for patients some of the surgical perspectives. We'll have time for questions, so begin thinking of your questions, type them in, and then we'll be able to answer them. We've got a fantastic group here who knows everything about surgery and IBD, and we can cover off any of the questions you might have. And you know, in the second half of our show, we'll go into more depth for physicians, talking again about surgical perspectives in inflammatory bowel disease, what's new and what's coming up. So let's begin. I'll introduce again Dr. Rachel Catteroo. Rachel, welcome to our show. It's great to have you here. And we'll have Rachel go through a little bit of a presentation for you to set the stage for your questions. So Rachel, over to you.
Thank you very much, Dr. Fedorik. I really appreciate the invitation. It's a pleasure to be here. I'll start off with going through some of the operative indications for inflammatory bowel disease. I'd like to break it up into elective surgeries versus emergent or urgent surgeries. So some of the reasons that patients will have elective indications for IBD surgery are growth retardation, especially for the younger patients that get diagnosed with IBD, failed medical therapy, where steroids or the anti-inflammatories or biologics are not working, fistulas with or without abscesses, obstruction where there's a tightening in the bowel that prevents things from moving forward, or malignancy. Some of the emergent reasons that patients will undergo an operation are for perforation, obstruction, again, that tightening which prevents anything from moving forward, severe bleeding called hemorrhage, or toxic colitis or megacolon, which can develop because of infection or severe inflammation. Now, I want to just put a nice diagram here so that you could see the normal GI tract. And we'll be referring to this throughout the show today, that you can see the different types of surgeries that are performed for IBD. Now, for our next slide shows where in ulcerative colitis, the places that is most effective. It can affect the rectum, or that's called proctitis. It can affect the left side of the colon, which is left-sided colitis, or it can actually involve the entire colon, which is called pancolitis, and including the rectum. Now, the areas that are affected most in Crohn's disease is actually the last part of the small bowel, which I've shown here, and that's called the distal ileum, and the first part of the large bowel, so that's the ascending or right colon. So you can see that it encompasses 70% of the parts that are affected, but it can affect the entire GI tract. The next slide here shows that this inflammation that happens in Crohn's disease can actually result in a stenosis or a tightening, which can lead to that obstruction that I described before, and other complications of Crohn's disease can be a fistula, and we can go into more detail and discussion about that later within the program. And the last slide I have here is actually what an ileostomy looks like. And an ileostomy is a connection of the bowel, and in this case, ileostomy means the small bowel to the abdominal wall, and then that empties into a bag. And here I've shown an ileostomy, but alternatively we can make a colostomy where the colon is attached to the abdominal wall and then empties into a bag.
Thank you, Dr. Catteroo. That's sort of a good discussion, good review of some of the aspects around the surgical reasons why your doctor may send you to surgery. And maybe I'll come to Dr. Catteroo and ask for a couple of clarifications. You mentioned the word perforation. And so if I have a perforation, what is actually happening to my bowel at that point?
With the term perforation, it actually means that there is and we can go back here for showing the emergent indication. It actually means there's an opening that shouldn't be within the bowel, and the enteric contents or the stool is emptied into the abdominal cavity. So as it sounds like, this is a very serious situation, and it can lead to severe infection within the abdominal cavity. So that's why I put it under emergent indications for an operation, and that's where somebody
So it's a hole in the bowel.
It's a hole in the bowel.
Right. And so, Dr. Coker, maybe you can just tell us, how would you know if I had a hole in my bowel? What are some of the symptoms that I might get?
So I think the most common symptom that people have with a hole in their bowel is pain, because not only will stool contents go into your abdominal wall, it'll be air, because your bowel always has air in it, and so it can make you have pain. The other thing is sometimes if it's kind of in a collection thing, it can be a little harder to detect if it's contained in a thing, and you can get infections like fever, different things where you just feel unwell. But the most common is abdominal pain.
Do you think it happens suddenly, or is it a long-standing problem?
So you can also get a perforation at the time of a colonoscopy when we do the scope test that we do often to help diagnose and to treat Crohn's disease or ulcerative colitis. And so that can happen quite suddenly during the test. But if people actually have a perforation, often it's a weakening, and it can be a gradual leak. And so sometimes if it's just a gradual leak, that's when people don't get as big of an indication, but they might get an abscess or collection of pus in their abdomen, which then sometimes it's just there's an area of your belly where it might be painful or really tender, and it's usually a difference. And once you get that infection, then that's when you can get systemic things like blood poisoning, where you'd get fever and
so it seems relatively serious. Dr. Catteroo, do you need to work quickly on that, or does a patient have a number of months to come and see you for a perforation?
Yes, the emergent ones are perforations. So that hole in the bowel needs to be addressed emergently, and that is meaning that we usually operate on someone who has a perforation within hours, not days. Now, in terms of, as Dr. Croker had mentioned, sometimes that perforation can actually result in an abscess, and that's when the body's normal inflammatory response can actually wall off that collection. And when it walls off, that actually allows more time for different types of treatments that we can address it, maybe in other ways other than just an operation.
Okay. So it's important that we covered off perforation. That's relatively rare, but it does happen, and it's quite urgent for you as a patient when it does. So now I want you to pause and think about some of the questions that you want to ask both the gastroenterologist or Dr. Catteroo. And so while you're typing in your questions, let me just move to Dr. Dielman. And Dr. Catteroo talked about one of the elective reasons for an operation would be that you failed medical management. So what does that mean? Does that mean that I've taken a pill and it didn't work today, or does that mean something different?
Well, actually, elective means that the word elect means you have to choose, Latin word for choosing the time that you can actually do surgery. So it's different from emergency surgery, where all of a sudden you get either severe bleeding or a hole in your bowel we just discussed. You have time to do something. So elective means that you can plan the surgery, you can actually talk to the anesthesiologist, you can make sure that your nutrition is up to par, because you don't want to go in there when you're malnourished.
And what's failed medical management?
Well, it could mean that you, there's several reasons. For instance, if you develop a stricture, like because of scar tissue, there's no medical therapy currently that we have. All our anti-inflammatory medication do not work for scar tissue. So that's one of those examples. Or you can say, the inflammation goes on despite all the therapy we throw. Otherwise, you can say, well, we throw in the kitchen sink at you and nothing works. So
essentially, you've tried all the different medications, nothing works. Finally, you might choose to remove that.
Right.
Right.
And you have all the time to kind of talk to the surgeon all about it.
Okay. Yeah. So another question here, again for Dr. Catteroo. You showed us an ileostomy. Why don't you join the bowel together? Why would you make a bag that empties outside the skin into a bag? Why can't you join things together?
There's a few reasons why we will not immediately join the bowel together. And some of those reasons that have been touched on that Dr. Dielman had mentioned is nutritional status. Often when patients are coming for an emergent operation, their nutrition status is quite poor. In addition, they've likely been on high steroid therapy. And with steroids and a lot of the drugs that are used for IBD, they are immunosuppressive. So that prevents that connection that we want to make with the bowel, prevents it from healing. So that would be one of the reasons that we do not do an immediate connection for 2 pieces of bowel. Another reasons we may not do a connection for the bowel is that anatomically it may not work at the time, and that may be because there may be it may be there may not be a place to connect it to. So later on in some of my slides, I'll show a total abdominal colectomy. So all the colon is removed and the rectum is removed. So all you have is left is small bowel, and that means there's nothing else to connect it to. So there are 2 big reasons why you would not do an immediate connection.
So another question we're having here is, I'm going to have surgery as a patient. Who do I need to talk to, Dr. Coker? When you're sending a patient for surgery, how do you approach that with them? Do they just automatically make an appointment with the surgeon? How does that connection work for me?
Okay. So I think for anyone that needs a surgery for inflammatory bowel disease, it kind of depends. Is that you actually usually need to see a gastroenterologist who's usually making the referral. And then once you have a referral, then a physician would see you. So if you're in hospital, there's people that are on call all the time, for the surgeons that are on call, and they would actually do consults at your hospital bed. If you're in more of an elective operation and you're in the community, and we would make an appointment and a referral, and then the doctor would triage it in terms of how urgently they would see you, and they would book an appointment for you to come to the clinic and talk about it so you could hear about what they're planning to do, what are the benefits and risks, and then they would make an appointment for the surgery if you decided that was the right way to go.
So how do you talk to me about the risks? Is it not too risky for me to have surgery? Shouldn't I just continue to stay on my medication?
So it kind of depends, like when all therapies, there's actually a benefit and risk. So for medicines, there's benefits and risks, and for surgeries, there's benefits and risks. And so if your benefit from medicine, if it's not benefiting you because you failed the therapies, just like you talked earlier, where we've tried all these different medicines, or Dr. Dielman used the kitchen sink example, is that, and if they're not working, then actually it might be better for you to have surgery. But if you've never tried medicines for Crohn's disease or ulcerative colitis, it may not be the best operation. And so there's kind of a difference between Crohn's and ulcerative colitis. So for ulcerative colitis, if we take out your whole colon, you can have ulcerative colitis, because how can you have inflammation of an organ you no longer possess? Right. But for Crohn's disease, it's a little more complicated about surgical options, because it depends on where it affects your bowels. So you can affect you anywhere along your gums to your bum. And so you obviously can't have your whole intestine removed, because you need to have nutrition and that sort of thing. And that's very difficult for us to replace. So that's why sometimes it can be a difficult operation. It might not be the right thing. We might want to try medicines first.
So let's move on to some of the distinct operations. And I'm going to ask Dr. Kataru some questions here about, so I have ulcerative colitis, and I've failed my medical treatment. I come to you, and as for a surgical opinion, tell me what type of operation you're going to do for me for my ulcerative colitis.
Do you want the slide?
Yeah, why don't we, this is a perfect opportunity just to go on to this set of slides here that I've put together for ulcerative colitis. There are 2 main operations performed for ulcerative colitis. As I mentioned previously, the ulcerative colitis affects the colon and the rectum. So you can actually get complete cure if we remove the colon and the rectum. So here on the slide, I've actually shown that the area that's affected here is the colon and rectum, and we've actually removed, in this one, it's called a total abdominal colectomy. So the entire colon's removed, except the rectum is left in place. So that is one surgery that can be done. And here I've shown on this diagram that an ileostomy is created. When you move on to the next slide, this is the second main type of surgery that's performed, is actually where we remove everything. So both the colon and the rectum. And this is for complete cure. And this is one example where I'm showing the ileostomy where it's not connected up.
So you would take out the entire large intestine,
yes,
and you'd leave me with an ileostomy. you ever just join me back together on the first day? Why do I have to have that ileostomy?
Yes. So this is, it depends again if a patient is coming in electively or emergently. Very important. So when I'm operating on emergent procedures for ulcerative colitis, the rectum is always left in. And the reason we leave the rectum in is it gives the opportunity to be able to do the pouch procedure. I like to leave those planes so when we actually do the pouch procedure, they have not been damaged at all. It's a very delicate operation to do the pouch procedure. And would I do an immediate connection? Not for an emergent operation. Yes, there are stages that you could do a primary connection for this, such as an ileorectal, so the small bowel to the rectum can be put together, or a pouch procedure, and we can talk more about that later on.
I think in the second half we're going to talk about that. Dr. Croker, you have a comment? You look anxious there.
I'm always anxious. So if you'd only connect to the rectum if the rectum was disease-free, is that true?
Absolutely, yes.
Okay.
Yeah. So it's not very common that we would ever do that. More likely in Crohn's, if it was a Crohn's colitis, that we may end up connecting to the rectum. It'd be very rare to actually do that in an ulcerative colitis patient. Sorry, thank you for clarifying. But that would be a point if it was only affecting the colon in Crohn's disease that we would potentially connect back up to the
That's where
rectum.
the disease comes back in ulcerative colitis. You leave the rectum in place.
Yes.
Then you can expect that you still might have high amounts of urgency,
Absolutely.
some of the bleeding you may have.
Absolutely.
So we talked about taking out the colon completely in ulcerative colitis, and then the patient no longer has ulcerative colitis. Question for Dr. Dielman, can we do the same for Crohn's disease? Can we take out a section of Crohn's disease, and why can't I be cured if you've taken out my disease?
Well, actually, I think we talked about that, and for the good listener, this means that Crohn's disease is located everywhere in the GI tract. So I can take out a piece of colon and come back in another area, or it can come back in another area of the colon. So you take a piece of the colon out, or you take a piece of the small bowel out, and then you just come back in another area.
So Crohn's disease always comes back, even if you take out a section,
Yes.
join it back together.
And that's actually a really good point, that why disease come back. We'll talk about it another time, but it is a very, very, very recurrent.
So Crohn's is not curable.
No, it's not curable.
Not yet.
Not
You have
yet.
to be on medication forever.
Ever, yes.
Okay. So let's talk a little bit, Dr. Croker, about some of the other elective indications for having surgery.
So I think you're talking more about Crohn's disease because we've talked about pretty much the only operation you'd have for ulcerative colitis, which is to have your colon removed. And so there's the different types of operations you might have. And so if you had a narrowing or a stricture like Dr. Katter was talking about, sometimes you're not emergent because a little bit of stuff will get through. You're not totally obstructed.
Tell the audience what the symptoms might be if you had a blockage.
So basically your intestine is a tube and it wants to move food in only one direction. And so when it's moving like your bowel contents or stool, it actually needs to move forward. So if there's a narrowing, or an obstruction, a blockage, then what happens is often people might get bloated first of all, and if things are really backing up, they'll get nausea and vomiting and things, and they'll get abdominal pain. Sometimes if things are able to get through, they'll get just pain and they'll see, oh, I know I ate something bad, and it'll kind of peristalse all the food through, and they'll get pain and it will relieve. And so, but persistent obstruction would get bloating and nausea, vomiting. And so people usually don't feel very well. And it's whenever you have that, you're also at risk of getting the perforation that we talked about earlier, where you actually get a hole in your bowel because there's so much pressure that there's a leak of the contents.
Mm-hmm. So we get back to that perforation as a complication because of the blockage.
Because of the narrowing, yeah.
Right. So one of the other questions then, Dr. Croker, is, or I'm going to ask this of Dr. Catteru, the types of operations. So if I have a scar tissue, do you have to take it out, or can you fix it somehow?
Yes, and meaning specifically in terms of strictureplasty, certainly. Stricture is a tightening in an area of the bowel, and the term strictureplasty, here you can see that tightening in the diagram that we've placed up. And to be able to open that widening, what we do is an incision in a longitudinal fashion, which is in the length of the bowel, and then we close it in a transverse manner, and that actually opens up that area that has been tightened, and that can be done in short segments. In terms of when I choose to do a stricturoplasty, it's usually to try to preserve the length of bowel, and that would be more likely in Crohn's disease, where a patient may have had many resections before and may be at risk because they've lost so much bowel of nutritional status, and I want to keep as much length as possible that we do a stricturoplasty.
So it's another option for some of the patients in certain circumstances.
Absolutely.
So one of the questions from the audience is, Dr. Kataru, what complications could occur when I go and have surgery? So maybe just give us a short run of what do you tell the patients about the potential complications of surgery?
Absolutely. When a patient comes to my office and we talk about bowel surgery and the risks and benefits, in terms of the risks for surgery, I always talk about bleeding. Bleeding is one risk that is inherent to any surgery that a patient will undergo. There's a risk of infection, and that can be infection inside, so those abscesses we talked about, or on the skin, so a wound infection. There is risk of damage to structures in the area that I'm operating in. And that could be, for example, if we're talking about rectal surgery, it could be nerve damage in that very delicate area. The other risk is that the bowel, and I'll show a diagram of just where the bowel is, just here, that I have one diagram here that shows the bowel on both sides. Right behind the bowel is the ureter, which is the connection between the kidneys to the bladder, and that can end up being damaged in some colon surgery. And if I'm doing connection between bowel, then one of the risks is a leak. So anytime you put two pieces of bowel together, there's always a risk of a leak. Then I go through complications that are related to medical risks, depending on the patient.
So it's really important. I think it can sound scary to the patients and our audience that there's all these complications, but it's really important for you to take a look at what would be the risks if I didn't have this operation. Failed medical management, I could go on to have many other complications, whereas the risks of surgery, while there are some, are much lower than not having the operation. And so these are things that we have to balance, risk versus benefit. Dr. Coker, you look anxious again.
I wanted to ask another question. So I think a question that patients often have when they come to the clinic for Dr. Kataru is, how long, if you have your colon out, would you be in surgery and be in the hospital? And how long until you actually could go back to work and do everything that you want to do? So what's your general recovery time that you think about?
Okay. In terms of how long in hospital, it all depends on the type of operation that's performed. But in general, and the other point is that it depends on patient factors, which I mean is the health status of the patient. So those things can impact on how long a patient stays in hospital. So if someone is more complicated, that's had heart problems, malnutrition, and lung problems, they may end up staying in hospital much longer. If someone is otherwise healthy and we're just going in for bowel surgery with a resection and connection, usually on average about a week in hospital.
And then how long before I can go back to work? I'm really keen to go back to work.
Absolutely. So I always...
1 week, 2 weeks?
For you, I might have to say different. I'll have to answer differently depending. So it depends. It depends on what a patient does and what type of job they do. And specifically what I'm speaking about is lifting. I always counsel any patient after any surgery on the abdominal cavity where I'm going inside the abdomen that they cannot lift anything heavy for 6 weeks. And usually by heavy, I mean anything over 10 pounds. And the reason is we want to prevent hernia formation.
Right. So I'm off work for a little bit of time here.
And yeah, absolutely. So there's other options other than, depending on where people work, but there's also light duty. And if someone isn't doing heavy lifting, they can return to work much faster.
Okay. So here's a question from the audience. This one's for Dr. Dielman. My doctor says he won't operate on me anymore because I could develop short bowel syndrome. So Leo, do you want to tell the audience what short bowel syndrome is?
Yeah, so short bowel syndrome actually literally means that your bowel is too short or relatively short for absorbing your food and your liquids. So and of course that's all applicable to small bowel surgery. And that's why one of the reasons for Crohn's disease we are so keen on preserving as much of the small bowel as possible. And that's why we're doing the stricturoplasties. Because in the old days when surgeons removed large pieces of the gut in the short bowel, or the small bowel, then that resulted in short bowel syndrome. Now what does it mean? It means that patients in worst scenario cannot even use their bowel anymore to eat, and they are dependent on intravenous fluids and so on. In a more favorable scenario means that you'll have a frequent bowel movement, that you can't really concentrate your stool anymore, or that you might have certain deficiency, meaning that you cannot have enough of certain nutrients in your blood that needs for the cells. So and lots of those things can be replaced. We have replacement therapy for that, but we need to be careful that people don't become deficient on those.
And I think over the years, we've seen less and less short bowel syndrome. We're very much more vigilant. The medication is better. Yeah. We're vigilant on not removing so much bowel, not so many operations. So it is a complication that can occur, but currently, and thank goodness, it's quite rare. I'm going to turn to Dr. Croker and ask this question from one of the audience. Dr. Catteroo showed us on her diagram that underneath the large intestine that she has to take out are lots of structures. The ureters are there. And what are the risks of infertility when I have an operation to remove my large intestine for ulcerative colitis?
So the risks. So that's probably one of the things that young patients, especially young females with ulcerative colitis, are concerned about. So whenever you actually take out the rectum or do the proctocolectomy when you and operate in that area of your pelvis, that's where your important organs are there, such as your ovaries and your uterus. And so whenever people have surgeries down there, it actually does increase your risk of infertility. And so if it's more important for men than for women, and because men's infertility is still present, but usually it's treatable with medications. However, women's infertility, sometimes, depending on the stage of life that they're in, they might choose not to have surgery that's involving their rectum at the time, and might choose to have a total abdominal colectomy where you leave the rectum in place so that you actually can preserve the tissues down there and have a bag for maybe a number of years, and then after you've had your babies, actually have a pouch created or some other operation where they do operate down there. And so the risk of infertility is kind of variable, and I think it's kind of changed over time. For a long time, we thought it was closer to 50%, and it's probably between 30 and 50% that people have infertility issues. And so I think it's really important to be considering about what your plans are for children and when you have or discuss an operation like this, because I think it's important for you to know what those things are, because it's an important part of
it may be important for a woman to have an ileostomy and then have the pelvic surgery completed at a later time.
Yeah.
Particularly the creation of the pouch. So that's the one that is the most...
Because you're into the pelvis,
you're in the area,
exactly. All of those
so you may
other
want
organs.
to do that particular stage later.
Absolutely.
So here's a question for Dr. Catteroo, and I'll read it. It says, Dr. Catteroo, I may need an ileostomy, which you've shown us the picture of, in the near future, and was wondering what are the effects on my fertility of just the ileostomy? So not the pouch or the other pelvic surgery.
So an ileostomy, the creation of the ileostomy alone should not have an effect on fertility. We don't usually go into that discussion. It is really, as we had just discussed previously, is really the dissection around the rectum and taking out that entire rectum, because that's where the nerves and the ovaries and uterus are. So that's more high risk for fertility. You should not have an issue with just an ileostomy creation.
So you should be able to have a normal fertility, have a normal baby, even with an ileostomy?
Absolutely, absolutely.
Okay.
But again, I think we need to clarify with that patient, did the ileostomy get created because they actually had the rectum removed? And then that would be exactly as we had addressed before. That's where more of the risk for fertility occur.
Right. So important as you're addressing this operation for ulcerative colitis with your doctor, that you have a discussion about whether the surgery is going to involve the pelvis or not, because that is where the infertility will occur. Another question for someone from Edmonton, a long question. And maybe I'll ask Dr. Croker this one.
I thought you were going to answer a question.
I'll take the next one.
Okay.
I had my pelvic pouch procedure done in 1998, age 21, for severe ulcerative colitis, so that would be appropriate. The colon was taken out, a pouch was done. My question is regarding delivery of a baby. So now this young lady is having a baby. Do you recommend a C-section or vaginal delivery? And it's a really good question.
Yeah.
It's
It's actually a very good question because it's a little bit controversial. And so I think for a long time people thought you actually had to have a C-section once you've had a pouch created. However, the data actually hasn't shown it. There's been many women with pouches that have had normal vaginal deliveries. I think the big thing is that when you think about it is that when you have a vaginal delivery, there's always a risk of tears, even for normal people. And so if you have a risk, if you do have a fourth degree tear, which is the tears when actually it tears all the way to your rectum or to your, then you actually have a risk of having incontinence. And so sometimes I think that's the risk that you need to discuss with your OBGYN in terms of those differences that you have. I think the other question is that for people that have Crohn's disease and have had history of fistulas, that's when, especially in their active fistulas, that's when we actually recommend for sure that you have a C-section. It's but a little different situation.
So I think there's some really important messages here for our audience out there. One is if you do have IBD, and it's good for you to attend a pregnancy clinic at the University of Alberta, whereby we deal with these patients with pregnancy and IBD. It's very important that you have a gastroenterologist and probably a high-risk obstetrician who can liaise with that gastroenterologist, arranging your medication schedules, advising you on some of these questions related to the types of delivery. So it's a team approach with you and your husband that needs to occur.
And the other thing we want to mention is that our June session is actually going to be on pregnancy the whole hour, and so you should come back and tune back into that one, unless you're going to deliver before then, of course.
So we're going to go on to another section. I have one more question that we want to try and answer here, and I know keep putting your questions in because we will get to them as the hour goes on. And this one, maybe Karen, Dr. Croker, you'd answered. I have Crohn's disease with lots of fistula. Should I have a vaginal delivery or a C-section?
So perianal problems, especially active perianal fistulas, should always have a C-section. I think if you've had previous fistulas and they've actually healed and are well healed, then the indication, it's probably safer for you to have a vaginal delivery. However, if there's any concern about it at all, I think it's important because that structures are never going to be perfect because you'll never completely eliminate the scarring and things like that happen with perianal fistulas.
So good to be talking with the gastroenterologist and the obstetrician and making that joint decision.
Making sure that they're okay before you go on,
Okay, so let's, we'll move on to the next half. Dr. Kataru now has some really important descriptions to talk to you about relative to the type of surgeries, and we've covered some of that already, but I'll have Dr. Kataru start her second part of the presentation. This one's designed a little bit more for the physicians, but the patients are welcome to stay tuned. There's lots of information for you as well, and don't hesitate to continue to put your questions in. Rachel.
Thank you. This slide we went over, this was the total abdominal colectomy, and that's where the colon's removed, the rectum is left in place. The next slide shows where the whole colon and rectum is removed, and it did show this one previously, but now I'm going to go on to show you what type of reconstructive surgery we can do, and this is with the pouch, and this is called an iliopouch anal anastomosis, and this is when the small bowel creates a new rectum or a neorectum, and here you can see in the diagram that small bowel is brought down into the pelvis where the rectum used to be and is created a new reservoir for the stool. If you go on to the next slide, you can see here that it's also termed J-pouch creation because the small bowel is formed into a pouch that looks like a J. And beside that, on the right-hand side of the screen, you can see one of the discussions that we have to have with patients beforehand is to talk to them about an increased amount of bowel movements because now the colon's gone that absorbs the fluid, so they do have increased bowel movements. And here for Crohn's disease, one of the common operations that we do is a terminal ileum and cecal removal, which is called ileocolic resection. And here the connection between these are done where you don't need an ostomy, for example, in the pictures that I've shown here. And then here's the strictoplasty that we talked about before.
Mm-hmm. Okay, so we've covered off some of the more complicated operations there. This IBD TV webcam will be on our website. That's www.ibdclinic.ca. And all of the IBD TV shows are archived there, so you can look at them and spend more time looking at those diagrams, looking at the specifics that Dr. Kataru has covered. Questions coming in here. So one of these is from a patient, which I think is important to get back to, and then we'll move on to the physician questions that are coming in. It says, I'm pregnant, and they tell me I may need a colectomy. So can you operate on people that are pregnant? And Dr. Kataru, how do we approach that? So complex.
Yeah, absolutely. We might have to tune into your pregnancy one that's coming in a few months. But in terms of operating during pregnancy, it's not the ideal situation. One of the parts in pregnancy that we don't like to operate on is especially within the first trimester. But in general, if we can avoid operating during pregnancy, it's always better.
Right. So in this case, we may choose to go and try some different medical therapy, push quite hard on that medical therapy, keep the mother healthy, keep the baby growing, and then try and get the operation done after the baby is born. If it's absolutely necessary, again, an obstetrician, a surgeon, a gastroenterologist making that decision with you, the patient, at the best possible time for you and the baby.
Absolutely. And we always remember that treating the mother is the best thing to being able to have a good outcome for the baby.
Right. So here's a question coming in from some of our physicians out there in Northern Alberta. I had a patient who recently had a pouch procedure for ulcerative colitis, but complains of having 6 to 8 loose bowel motions per day and some nocturnal leakage. So that means they're incontinent a bit on their underwear. What can I do to help him? I don't know who was going to take this.
I'll take this one.
Maybe I'll just, I want to ask Dr. Kataru, you said that they're going to have more frequency. Why is that?
The next slide after this. Oh, the pouch procedure. So the reason here, I've just put up the slide showing the J-pouch creation. As you can see that in this procedure, we've removed all of the colon. The colon is what absorbs the water to be able to make stool formed. So once that's gone, we have to rely on the small bowel to adapt. And hopefully it adapts well enough that the bowel movements can become less. When I look at that question, I'm actually think about this slide, because when you look at the slide, on average, 44% of the patients will actually have between 5 to 7, and another 40% will have 7 to 9 bowel movements. So that's about 80% of the population. So that's actually within the most common amount of bowel movements per day.
So you rarely go back to one form bowel motion per day when you have this procedure. You always accept some amount of diarrhea, right? So Leo, do you have a recipe to try and slow the diarrhea? What do you tell these patients?
Yeah, so
They have to get on a plane, fly to Toronto, they can't have 10 bowel motions while they're taking off.
yes. So
What do you use?
what I typically use is that Imodium can be used in these circumstances. Should be used, particularly if it's.
So what's Imodium? Just to
so
explain it to the patients who are still listening.
Right. Okay. For the Imodium, actually is a drug that will slow your bowel down. So what you may hope for that it has several things. It slows your bowel down. It also, in some instances, it may even strengthen the sphincter muscle that you have. And that's actually come this question about nocturnal leakage. That could be really a problem in patients who had finally go through this entire operation, this pouch procedure, and all of a sudden they're incontinent. Well, that's really bad.
Right.
And so there's medical solution for that. It's not like, this is the end of the world. It's a failed operation. And that's actually a question I had for Dr. Kataru. Do you do those so-called anal manometry studies before surgery?
Well, on one of the slides, I put up some of the contraindications for a pouch procedure, and one of them is poor sphincters. If you have sphincter dysfunction, it would be a contraindication to creating a pouch procedure, because we do not want someone being recreated and not being able to be continent. So usually it's actually just on clinical exams, so it's not a test that we often do routinely, but if there's any worry in terms of that, we can have that done.
So you want a patient to have a good tight sphincter, be able to tighten that sphincter to hold the bowel contents in. That's really important. And I think, Dr. Dielman, you're right. The only medications we really have are these antidiarrheals to slow the gut motility, slow down things moving to the end of the bowel, allow more water to be absorbed, things get a little more solidified, and gives you better control. So more solid, less leakage, that type of thing.
There's an exception that actually leads into one of the questions here, said what is pouchitis? Because what actually can happen in these pouches, that these pouches, just like ulcerative colitis, they can actually have some inflammation, likely because of the reservoir they now create for lots and lots of bacteria.
Right.
And if that pouch gets inflamed, because pouchitis basically means inflamed pouch, then you'll have more bowel movements than usual, and then it can easily be treated with antibiotics, and then that means that you, instead of having 10 bowel movements a day, you might actually come back to your baseline of 6 to 8, as you mentioned.
So if a patient goes to see their gastroenterologist or doctor or surgeon with lots of diarrhea after a pouch, the surgeon or gastroenterologist will probably do a sigmoidoscopy, colonoscopy, look inside that pouch, make sure it's not inflamed. Yeah. If it's not inflamed, they'll treat you with antidiarrheals. If it is inflamed, Dr. Croker, what are you going to treat an inflamed pouch with? Pouchitis.
Pouchitis. So pouchitis is an interesting thing, because I think Dr. Dielman alluded to it, is that we think it's because of change in the bacterial flora. So we all know that within our intestines we have lots of bacteria, and when normally the higher up in your GI tract you have less bacteria, and in your colon you have the most. But when you get that altered bacterial flora in your pouch, because there's stasis, because you're trying to get it to act as a reservoir, then you can get something called dysbiosis. And dysbiosis we usually treat with antibiotics, so usually ciprofloxacin and flagyl, sometimes amoxicillin and clavulanate. But I see somebody asked about VSL3, and VSL3 is a probiotic, I think, of 8 different bacteria that actually can also be used. And so there is some evidence for that. So I would never use a probiotic with bacteria with an antibiotic, but I would use either one at different times. The difficulty with VSL3 is it's not very cheap, and it's not covered by drug plans. And so unless you have some sort of plan where you have a health spending account or whatever that you can use to cover it, it can actually be quite expensive. Whereas antibiotics, even though ciprofloxacin isn't inexpensive, it actually is usually covered by plans, and so it can be used. And so the thing about it is with pouchitis, I think one thing to note is that not everybody's ever going to get pouchitis. So when you get a pouch, some people won't get pouchitis. Some people only get pouchitis once, and they'll never get pouchitis ever again. They'll get treated with antibiotics. Things will go on great. And then there's a portion of people that will actually have recurrent pouchitis, and that's sometimes the most difficult to control. And then over time, if you have recurrent pouchitis, sometimes we end up treating it kind of like Crohn's disease or ulcerative colitis, with different medicines that will actually reduce inflammation, steroids, Imuran, or even anti-TNF therapy. And so sometimes we go up that pyramid that we talked about in the previous sessions to treat this. And this is sometimes it's difficult to distinguish, is this Crohn's disease or is this just pouchitis? And that's partly what the endoscopy would help figure out.
We've covered a lot of things there. Let me just try and summarize what you said. you said that pouchitis is an inflammation that we would normally treat with antibiotics. Often goes away, but sometimes becomes recurrent and comes back, and that's a place where you might have recurrent antibiotic treatment or even use VSL3 as maintenance. But then sometimes it even gets worse, and then it actually develops into chronic or Crohn's disease sometimes can develop inside that pouch. So there's many different stages. Fortunately, that's quite rare because most of our patients do really well with pouchitis.
Or maybe just get one episode or never get an episode.
Right. So it's uncommon that you get those types of complications we've talked about, but it's important that we mention them here so that you're aware of them. And another question here from one of the doctors. My patient had ulcerative colitis, had surgery, so had their colon removed, And now, do they need screening colonoscopy, screening endoscopy of the pouch? Dr. Ketteru?
This is a great question, and it really outlines how important it is that you understand what surgery was done for your patient. And I think it's a perfect point that I can show on the
Why don't you
diagram
take
here.
your diagram
Yeah,
and-
I'll show the diagram, because this is really important to find out what surgery was done. So as you said, that they had a pouch created, but you want to find out. So the pouch actually, with that, all of the colon is gone and the rectum. So we'll focus on the rectal area here. That's gone. But the most important thing is you need to find out if a mucosectomy was done. So that's the
Ooh, that's a big word.
yes. So the
For the patients out there, tell us what that means.
That is actually the lining, the inside lining of the rectum, if that was actually removed. Because if that inside lining of rectum is removed, that decreases the risk of recurrence of ulcerative colitis or cancer.
Yes.
And if that mucosectomy was not done, then yes, they should have a screening of that pouch to be able to outline that. And then in that question they asked if part of the rectum is left in, really important to read that operative note to find out where did they actually connect that bowel or that pouch. So that is something that I would look into in more detail.
So I hope out there you saw that diagram. It was a bit of a glare there, but it's really important that you understand and discuss with the surgeon exactly what operation is done. And if all of that's been removed, there's no more colon left, no more rectum left, then screening colonoscopies are not required.
So the key thing is basically the existing colon. If that colon is completely gone, including the rectum, then your risk is average. But if it's there, then that's also the long-standing risk for ulcerative colitis, leaving the colon in. That could lead to some of the questions that I see, like how do you balance the risk of continuing an ongoing colitis, ulcerative colitis, versus surgery. And of course, what we do in general practice, if somebody has long-standing ulcerative colitis beyond the rectum, then you have a higher risk of colon cancer, and we do surveillance colonoscopies on the long term.
And I think that question comes right back to balancing risks and benefits.
Yes.
So you've had long-standing ulcerative colitis, you're optimally controlled, but you're not really better, you're not completely healthy, but you're getting by.
Yeah.
You then have to start adding up all of those risks of not doing something else. So the risk of having long-standing ulcerative colitis with the risk of colon cancer, the risk of now being sick all the time, of developing iron deficiencies and anemias, not being able to work every day, taking time off, the risks of all that medication that you have to be on. You have to balance all those risks versus the risks we talked about of colectomy and pouch formation, or a permanent ileostomy might be another option. And so you begin to balance those risks, and you need to have really meaningful discussions with your gastroenterologist and family doctor about what those percentages are. How many times out of 100 will I get problems not doing something? And how many times out of 100 will I get problems related to my surgery? And you'll often find that the risk of not doing something surgical far outweighs those rare complications that occur with surgery. So these are discussions that you need to have.
Absolutely. I want to also touch on that by the time that we end up seeing them for surgical management, that after the surgery, patients will often say how much better they feel. And in some cases, they're even able to decrease the amount of medications that they were on preoperatively, and they feel much better. So even though we've said a lot of scary things about what surgery can be, or even ending up with an ileostomy, the benefits are sometimes worth some of the risks.
Right.
Do you think that patients talk among each other about these things? I had a few patients actually, it's like, oh, it sounds very scary, and so I had the patient talk to somebody who underwent the procedure.
I think that's really good to be able to have support groups and be able to discuss amongst themselves, especially when it comes to discussions about ileostomies and colostomies.
Right.
Those are often very scary situations that patients may end up in, and being able to learn that it's very manageable and that you can lead a normal life with one, that no one knows that an ostomy's there is really helpful.
Right, and most physicians will have patients who've agreed to talk to you about what it was like to have the operation, what it's like after the operation, and maybe they've even lived with an ostomy. And so it's important to ask your doctor, if there are patients around like that, We also have nurses who specialize in these type of surgical operations and in the ostomies, so good to talk to those people as well. Another question coming up here, I want to switch a bit to Crohn's. So would you ever do a pouch if I had Crohn's disease? We've been talking about pouches and making these pouches for people with ulcerative colitis. So now I have Crohn's disease, Crohn's colitis. You're going to make me a pouch?
I'm glad you asked that question. It's an absolute contraindication to do a pouch procedure.
And why is that?
And the reason is as we mentioned before, as Dr. Croker had mentioned, that Crohn's can affect any area of the body from gums to bum, and that also means a small bowel. So what ends up happening in the pouch procedure is we make a new rectum out of the small bowel, and then that means that stool can sit there, and it can end up resulting in inflammation and recurrence of Crohn's in that area. And to have that happen in a pouch near the perianal area can result in a lot of complications that patients don't want to have, or we don't want to also have.
So in medicine, we rarely say never, but
we never do it by choice.
I think I'm going to challenge you now.
Yes.
What if your small bowel is completely normal?
And it was a diagnosis of Crohn's disease.
Yeah.
I personally would not do a
Still
pouch
won't do it?
procedure, but as we said, never say never. You may be able to
That's
find
right.
somebody
That's
to do it,
never.
but I
Or
would say
maybe.
that there
Yes.
may be somebody who may do that, but I don't think there are people who would do that with knowing it's Crohn's disease because of the severe complications that can happen. So I really urge a good discussion happens if Crohn's patients is being offered a pouch procedure. I think you have to take that with real care.
Yep.
So another question here, again, about Crohn's. And the question is, the patient, Dr. Croker, I'm going to ask you this one, has had a pouch procedure, and now there is, in the small bowel that is draining into the pouch, there's inflammation. Is that Crohn's disease?
Yeah, so I think what it is an interesting question. So you can get something called pre-pouch ileitis, where often people can get anemic and things like that. I think it kind of depends on the severity of what you see. So sometimes it looks a lot more like Crohn's disease and than just a little bit of inflammation. And so I think you have to really be careful. I think it's a lot greater chance that it is Crohn's disease if you see inflammation beyond the pouch, not just pouchitis. And so often we would treat that a little more aggressively and usually use immune suppression for that. And so that's it's a little bit about what you're talking about when you don't want to do it ahead of time for it because you're actually at risk of developing these complications and requiring to be on the same types of medications that you would have been on before, and yet still have a pouch and so have 6 to 8 bowel movements per day, and still require pretty significant medications to stay well.
Okay. So another question here related to colectomies. Dr. Catteroo, or anybody can answer this, but Rachel, I'll ask you this one because it's a bit complex. The patient has known ulcerative colitis, but also is one of those relatively rare patients with ulcerative colitis that has perianal fistula. So would you do a pouch in someone with ulcerative colitis and perianal fistula? Do you think there's a risk of problems occurring there, or would you, how would you?
I think this is a nice time to put my last slide on so that it can describe to the audience what a fistula is in the perianal region so that people can decide if they would want to have it done. And you can see here, a fistula is a connection between the rectum and the skin in the perianal area. So what is being described by the question is that they have these fistulas that are going to the rectum and they have a diagnosis of ulcerative colitis. Is that correct?
Right, correct.
And fistulas can happen in anyone. It doesn't only have to be Crohn's disease, but again, I think a very thorough exam to find out if this was Crohn's disease, and it still puts our radar up to make sure that this isn't Crohn's disease, because that would be the last thing that we'd want to do, is create a pouch which sits in that area where the rectum is and the small bowel that may have a development of fistulas. I would first, if this patient wants a pouch procedure performed, I would first address the fistulas, get those under control where we have ways that we can treat them and try to eliminate it if possible before I'd even decide putting in a pouch in that area.
So you're going to be really cautious.
Very cautious.
In that type of patient.
Very cautious, and I would say treat the fistulas first, because the last thing you want is an operation area that has already scar tissue and inflammation that may not heal well. So that's not setting us up for success.
Mm-hmm. So another question coming from a patient, and it was back on a few slides. I have Crohn's disease of my ileum, so that's understandable.
Yes.
But you showed me pictures where you have to take out the cecum and the ascending colon sometimes. So why do you not just take out my ileum? Why do you have to take out all that normal bowel? That doesn't seem fair.
Yes, that's a great question. I'm going to go back to my diagram here, and I'll try not to have glare. So please let me know if there's glare.
We have to tilt it a little bit,
Tilt it a little bit forward. Okay, so
Oh, the other way? Okay.
let's erase our last area. So they have disease of the ileum, which is the last part of the small bowel. And the question is why do I need to take out the ileum and part of the cecum? The main reason we do both is because it's actually the blood supply. So the type of operation that we do, actually the blood supply goes all the way back here. So to be able to do that resection and have a good connection is that we usually end up taking a little part of the large intestine. It can be smaller if it's not affected by disease process. And then what we do is that is removed and it gets connected here, and we sew it together. And that would be called the anastomosis. So that would be a very limited resection. The amount of colon that's removed, if it's only small bowel disease, is very minimal and is not even anything to worry about.
Makes me feel better that I don't have to worry.
And your appendix is gone.
The appendix is gone. Absolutely. And sometimes in Crohn's disease, it's nice to have that appendix gone because it eliminates that question when you have right lower quadrant pain, is it appendicitis or something else? So that is removed in that operation.
Okay, a couple of short snapping questions here. We've got about 3 or 4 minutes left. Dr. Dielman, taking out my colon for ulcerative colitis, will that solve all my other problems? And I think what they mean is joint pains, the skin rashes that go along with inflammatory bowel disease.
That's actually a great question. I mean, what it actually refers to is the so-called disease not only in the colon, but also in the so-called outside the intestine, extra-intestinal manifestations. And sometimes the joint pains are coinciding with the inflammation. So that you may benefit, but there are some joint pains, such as like ankylosing spondylitis, Bechterew disease, that are completely not related to your activity, and they can still go on.
still have some of these extra-intestinal manifestations.
Still have go on. Yeah. Skin rashes, the same problem.
And I think we have an episode coming up on extra-intestinal manifestations.
Actually, that's a
so
great
let's save some of that discussion.
Yes,
absolutely.
Totally.
Here's a question for Dr. Croker. Had my operations for my Crohn's, and now my doctor tells me I still need to take medications. Yes or no? Why would that happen?
Oh, that's a very good question.
How much time do you have?
I only have 30 seconds or something. So I think that what it is that we know that when you take out part of your bowel for Crohn's disease, that it comes back. And the most common place that it comes back is what we say proximal to the joint. So just a little bit ahead of where it used to be before. And so we actually do use medications to reduce the risk. Sometimes, depending on different things, we often look pretty early on after about 6 months, 6 to 12 months afterwards to make sure you didn't have recurrent disease. Because we might have to be more aggressive because some of the medicines we use to prevent Crohn's from coming back are pretty mild. And so we're hoping that it doesn't come back. But because we know it comes back in about 90% of people within a year with some ulcerations right in that area, we actually want to treat it seriously.
Is maybe.
For sure.
You could use it in some of the high-risk patients, but not everybody.
Most people.
Perfect.
I'm still waiting for you to answer a question, though.
Next week, you'll have to wait for my answers for next week. Stay tuned. So, with that, we've come to near the top of the hour. I just wanted to thank the audience, the physicians and patients out there from across Canada and Northern Alberta who put in those questions. They're great questions. There are many more that we haven't been able to answer, and we will get to them on our frequently asked questions section of the website, and that is www.ibdclinic.ca, www.ibdclinic.ca. Wanted to thank our sponsor for this week show is AbbVie Canada, and coming to you, Dr. Kataru, our guest, thank you for coming. You've been great. And our two stalwart gastroenterologists, Dr. Dielman and Dr. Croker, Once again, thank you very much. And ladies and gentlemen, we'll see you next month, the same time on IBD TV from Teachers Media, Edmonton, Alberta, live and direct.